morning, and sir, thank you for this wonderful opportunity, and also my co-panelists in this, Dr. Monica and Dami, sir. We've learned so many things from each other over the last many years. Today, the topic given is the Wavelight Plus, which is something which is trending in refractive surgery for your eyes. No financial interest linked to this. Been using this technology for the last close to a year now, and now it's introduced officially, but we have been using it for different other research activities. If you look at the Alcon's journey, it started with wavefront optimized. It's more of preserving the corneal asphericity than wavefront guided, the topo guided, and also in between there is FCAT and the QCAT and all these factors which Dr. Dami has shown very beautifully about its potential. And some of it I feel could have taken to the next level if Alcon had understood or listened to Dr. Dami's work on this, and then probably they could have brought this up much earlier than what it is today. So when you look at the standard treatment, it's basically based on your manifest refraction, the wavefront treatments based on the ocular wavefront, and it has its own customization. The Contura has a mix of what it can do on your corneal topographies. But when you're looking at the fully personalized one, you're looking at the complete optical system of the eye, which starts with your cornea, the anterior chamber depth. It's like the formulas of today compared to what IOL formulas of many years back, when you had you had a model eye, which is and most of your formulas was based on that. So if you look at these two factors which I already mentioned, it is most of it with the values what you're getting of how your ablation is. It's like etching a lens, a glass power onto your cornea, and it uses the standard one for all theory, use the Gullstrand model, and we know it does have its own challenges and limitations, and all laser profiles are based on this. So when you look at ray tracing, which is a completely new dimensions, it's not based on one model of the eye. You remove the model of the eye completely out. Based on Snell's law, where you use multiple rays of light and how it forms on the retina, it uses every aspect of it: the anterior cornea, the posterior cornea, the lens, the thickness of the lens, and things like what you would actually use in your IOL calculation, because that's why your IOL formulas and calculations have become so important today, and all optical elements have been measured. So how does it help to customize? It looks at a complete topography, both anterior and posterior. It uses your biometry, and so for that we need to have machines which works on it, which looks at both. So that's where you look at the Innovice, where you have the Pentacam, which has an abrometer, and the Scheinflug imaging, which is your traditional topographer, and the laser interferometry. And then you get all these values out there, which is fed into a digital model. We call it the virtual digital model. And of course, now everything has AI built in it, and you create a front surface ablation because based on your entire model of the eye. So this is how Innovice works. Innovice is nothing but a Pentacam, and this is the screenshot of a Pentacam out there. You need to take at least 4 wavefront scans, so it takes a little longer time. It's not like one scan. You have to take multiple scans. You have to have a proper size of the pupil. If your pupil size is too big, it doesn't give you, it asks you to go back. So you have to dim the light, put a cloth sometimes. And you have to at least have 2 wavefront maps which match with the subjective refraction. And in the past we were looking at 6 measurements. Now we have come down on this, and then it takes all the other parameters. What's interesting here is it is supposedly helps to even factor in your epithelial remodeling. There are senior surgeons like Dr. Vinod sir and Dr. Dami here. If you really look at your earlier generation refractive surgeries, one of the major cause of regression for you was how the epithelium was remodeling, the change. So a 10-15 microns of epithelium would and make your patient go back to change of asphericity or change in your corneal, corneal spherical equivalent. So what we did was we looked at, compared a contura with this one, which even now it's one of my favorite procedures. And what is interesting here is not much of a difference in the gross quality, quantity of vision, but the gain of line is definitely more. And this is something which is early data. You have more gain of lines than any other procedures I compared with. Smile, Sil, Contura, Wavefront Optimize. So one of the things is that it is giving you an extra gain of lines. It's not making you better than Contura in getting 20/20 vision, but it's definitely giving you much higher gain of lines, which we do today. So why do we still need customized laser? Yesterday there was a debate and they said, will Silk, Smile, AIOS will take the customization off? It will never take the customization off, because at this point of time, I don't foresee in the near future also, the lasers are the only one can create that customization what we see with the best of procedures. For example, if you look at this person with the 3.5 diopters refraction, the cornea looks okay. Look at the epithelial maps out here. The epithelial is irregular. So when you look at the MS39, the MS39 actually gives you the epithelial cylinder. There is an epithelial cylinder coming from close to around 0.5, 0.75 of epithelial cylinders. Even though the patient is not accepting any cylinder here, maybe he's balanced by the lens, but he's still having an epithelium which is quite irregular. An irregular epithelium induces cylinder, which is very important. But you also have changes in your posterior corneas. But what this machine does is it factoring in all these components of cylinders, and it's giving you that this is what you would probably need to correct rather than just doing a non-cylindrical correction. So that means that you're factoring in the multiple things. Even in a zero ablation, you can see that there is a lot of correction it does, more of trefoil, which is probably coming from an epithelium or the stromal level. So it is true customization, and this is a map which I'm quite impressed with the new technology called IOS. IOS is a company which makes refractive lasers. They use pure, they're more of a PRK based machines. It was there in the booth here. And they have an abrometer called Precisio, which gives you a ray tracing refractive map of your epithelium, which is very exciting way of looking at it, because that this ray tracing of Precisio takes care of the ablation from the epithelium. And this is a ray tracing. This is not a thickness map. This is a ray tracing refractive map. And when you do a ablation profile, when you're not bothered about your epithelial irregularity, do a ray tracing, you do a customized one, your epithelium will grow in any way you want. But when you create a beautiful shape, your post-ops will be more regular in shape. This is a ray tracing dioptric gradient change which happens. So that means that there is definitely some role of creating a more gradient change on your epithelium. And there's a few epithelial maps. The blues are the ones where your refractive changes a 1.4 diopter ray tracing refraction on an epithelium compared to the surrounding. So you can see that there is so much of change which is happening, which can be corrected. So what is the patient feedback? They report sharper vision. We did not tell them we have done a new procedure, otherwise his brain gets biased. And there is definitely a more better level of the quality of vision. The quality is one, and the gain of line, which is the first time we are seeing that level of gain, which we can push the limits of gains. So higher visual accuracy, because using a total ray tracing, you're using a pupil recognition, you're using the pentacam data. Aberrations, I don't see it's heavily reduced, but it's still, I feel, is better than what I've been seeing. And it is definitely a one step above if you are adopting to a newer technologies. And even though I'm a Silk Smile surgeon, the quality of vision day one is, I don't think any of these machines can really match to the level what we are getting here. Thank you, and thank you, Vinod sir, for this opportunity.
Thank you, sir. Thank you for such a wonderful presentation. Just one or two questions, sir. Do you think totally ablation-free is a perfect model for the eye? Because some of the ablations may be helpful.
So uh, when we did not have proper understanding from a time when Monica was there, Dr. Dami and all of us were part of the Alcon meets, we used to harp about zero aberration concepts.
Yeah.
Then we realized the zero aberration doesn't happen because even if you create zero, your lens is going to be taking over from there and one or the other culprits will be there. So what Innovice is trying to do is, it is factoring in the epithelial remodeling, and I think both of you as seniors would agree that challenges is how the epithelial remodels. You do a silk or smile, one of them, and you create a beautiful system. After 1 year, you see a ray tracing map here with one diopters of uh, thing, you are finished. And I mean, for both of you, anybody wants to be part, visit our lab and work on this is a fantastic optical thing, especially Dami sir, when you are looking at your Q changes and how an epithelial remodeling will change your Q or even Dan Reinstein's work. It's a fantastic one. And the second thing is, sir, your collagen, when you have a laser which you burn, if your collagen is strong, it has a different way in which it behaves. If collagen is weak, the collagen fibers after you heal gets remodeled in a different way. So whatever SA coma you wanted to correct gets nullified because your healing becomes completely different. And that is where I think ray tracing takes into an account of every layer and gives you a much organized map.
Right. And if you compare with the topographic guided one,
Quantity is the same, but the gain
yeah,
of line is more.
okay.
And this is consistent even with the other two published work on it.
So the aberrations are already on the cornea. Whatever we were learning that in wavefront guided, there's hardly 4% of the patient who had got RMS more than 2.5. So is there any,
So
you
what
see,
happens is when you're doing a topo-guided contura, you're correcting the cornea beautifully, then the lens is not factored in. When you're doing this procedure, it takes into the accommodation change. It also looks into the how much of the lens is giving you an how you balancing the aberration. So AI will then decide how much of aberration I should actually correct both from the cornea and the lens so that I can balance it so that I don't create an imbalance between them. The whole challenge with Contura, why we were not getting more gains, is that you create a good corneal aberration free zone, but your lens aberrations is not balanced. In ray tracing, because it's a forward ray tracing, you look at everything. It also knows how much is the lens compensating and how much is lens adding. So you get a complete one compared to a non-complete one. For example, if Dr. Jatlani wants to tomorrow do a LASIK on an amblyopic eye, uh, this would be the way to go because an amblyopic eye has a huge amount of lens which is going to compensate for him. He treats the power of -6, but the lens is still compensating. The whole amblyopia in a child gets completely nullified. So if you do this, you are completely looked at the entire optical system, so he can look at how much of lens is actually playing. So it's a huge leap in the way we look at refractive modeling.
Very good talk. Always it's a pleasure to hear you, Dr. Shetty. But my question is, we have one culprit, that is the epithelium. I have seen it. It's the only culprit in refractive surgery, which probably with all this we have come to prove it. But in one of your talks, you were mentioning as immunomodulators to be given
For all of them.
for all of them. What and when to start these?
Sir, I have a scoring system, simple one. Of course, I will not talk about my biomarkers because it's not come to the clinic yet. The patient is contact lens intolerant, and the patient has a meibomian gland drop more than 25%. The patient has a high OSDI. The patient has a T-but of less than 5. And patient has nociceptive symptoms, like he complains that I can't see the light, I can't face the AC and all that. You know this person has already high threshold of inflammation. These patients, I start them 2 weeks prior. these immunomodulators. I can choose between cyclosporin or lifitegrast. Lifitegrast works faster so that I can reduce it to 1 week. And then I keep them out for 3 months and along with the drops. But if these patients don't have any of the symptoms pre-op and they're quite okay, then you don't need to bother about it because epithelial remodeling is usually well. If a patient is a contact lens intolerant, there is a 96 to 97% chance he will remodel post-surgery very badly. Where I think ray tracing helps is it has already factored in the component of how the shape is, and it will also have an AI which will tell you this is the shape of the cornea which is going to be, and this is how the epithelium will re-go in that area. So the laser spots are given in such a way that the components of healing gets more nicely balanced compared to a non-ray tracing procedure.
Rohit sir, a small question. I mean, it's regarding Trehalose. I had heard in a NN meeting only that it causes epithelial remodeling.
It
So,
causes not remodeling, it causes epithelial swelling in the first few weeks. Time the epithelial swelling goes because it contains sugar. Any sugar has a little tendency, so it does not create a change enough to be bothered, but after long term doesn't change much.
so my question is, should we use it in post-LASIK patients or not?
It's a remodeling by the way that it doesn't allow the unregulated growth of epithelium. So
Okay.
that means it doesn't allow it to heap up epithelium, and when you do a LASIK or one of them, it has factors to improve the nerve growth.
So we can use.
Yeah, that is my drug of choice for all post-op patients.
Okay.
Now, once we have got a regression and we have proved that it is epithelial hyperplasia or irregular epithelial, advise at that stage.
PRK sir, topo-guided PRK.
Any immunomodulators first?
You give a immunomodulators for 2 to 3 weeks, but when you use mitomycin, irrespective of how much you burn, I keep the mitomycin amount double, means the time double, because epithelial remodeling is driven by TNF alpha driven pathways. So even if you treat a 0.25, you'll get a very bad haze. So epithelial remodeling cases have to be re-looked at it completely differently.
Will tell us how much is the refractive error by the epithelium?
No, sir, not now.
Or regression? No.
Only your MS39 will tell you.
Okay.
So you will have to combine both the technologies.
Thank you.
I'll go back to one session and come back after
Sir,
that.
thank you so much. It's always a learning